Okay, I think we might get started. So hello and welcome. My name is Sharon Bishop. I am a PhD student at the Johnson-Shoyama Graduate School of Public Policy under the supervision of Dr. Marchildon. On behalf of the Western Regional Training Centre, it is my privilege today to be able to introduce to you our guest speaker, Amy Zarzeczny. Amy is an assistant professor at the Johnson-Shoyama Graduate School of Public Policy at the University of Regina campus here. She also holds a position as an external research fellow at the University of Alberta's Health Law Institute. In 2008, Amy obtained her Master's in Laws with distinction from the London School of Economics and Political Science. She holds many awards and distinctions to her name. She has 2 current research grants, one for which she's the principal investigator. Amy is presently the academic director for the Masters of Health Administration program offered by the JSGS, and teaches courses in health policy, health law, and health administration, organization administration. Amy's research focuses on health law and health policy issues, with a particular interest in the legal, social, bioethical, and policy challenges associated with emerging biotechnology and medical research. So it is my privilege and honor to be able to introduce our guest speaker today, Amy Zarzeczny.
Thank you for that kind introduction, Sharon, and thank you to the WRTC and to all of you. I'm thrilled to be here today. This is a wonderful opportunity and one I've been looking forward to for some time. For those of you who follow the WRTC, this presentation topic may have sounded somewhat familiar, and that was because I was originally supposed to give this talk a little over a year ago, but it was canceled at the last minute when my daughter decided to make an unexpected arrival 3 months early. Now I'm happy to report that she's doing well. The other benefit of the change in timing is that whereas a year ago I was going to talk today about a new research project that I was embarking upon and kind of give you some foresight into where we were going, I'm now able to speak to some of the results from that research project and the preliminary analysis. So perhaps this was all meant to be in any event. My topic today is stem cell tourism, the position, involvement, and the role of professional regulation. Now this may seem like a fairly focused topic, but I approach this issue as an example of, as Sharon noted in my introduction, an emerging area of biotechnology that does raise a number of policy challenges from a legal perspective, from an ethical perspective, from a disciplinary perspective. So although this is a focused topic, it presents a lot of examples and a lot of fodder really for us to analyze similar issues in comparable fields. So how does this topic connect more broadly with health policy research? I think it's a couple of key levels lenses, I guess, through which I view this particular area. The first is that it is an exemplar of the issues associated with medical tourism more broadly. So for example, the challenges that our Canadian physicians and other healthcare providers face when asked to provide follow-up care by patients who receive treatment overseas when they know little to nothing about the kind of treatment that individual received, or they're asked to provide pre-treatment tests or screening that they would not otherwise provide as part of that patient's general standard of care, again, in preparation for that individual to go overseas. The challenges and the costs that our healthcare system may face upon being asked to provide follow-up care upon return, particularly in circumstances where treatment has not gone well and that follow-up care may prove complex or costly to our system. There are issues around protection of minors and other individuals with limited decision-making capacity. The list goes on. Some of these may sound familiar to those of you who may have followed the debates here in Saskatchewan and other provinces regarding the treatment for multiple sclerosis that was popularly referred to as liberation therapy, or CCSCI. A lot of the similar kinds of challenges were felt in that particular context. So stem cell tourism is just one example of an area where we can kind of focus our analysis on a particular field to look at these kinds of issues that come up in similar areas. From a broader perspective, stem cell tourism also represents, I argue, a perfect storm, if I can use that somewhat overused phrase today, that brings together a number of very current and complex issues in the health policy realm. It is an area of emerging biotechnology. It engages a lot of attention from the news and popular science media reporting. It brings to the forefront the power of the internet and social media to connect individuals, facilitate the sharing of information, rapid access to information. It also engages the private market for medical care and really brings in that financial aspect, the money to be made there. And all of that comes together in a very sympathetic context of individuals and their families who are often dealing with very difficult circumstances. So again, here stem cell tourism is merely one example of an emerging area of biotechnology that raises these kinds of challenges. The direct-to-consumer market for genetic testing is another example. Again, the MS liberation situation is another. So it is not unique in that regard. It just gives us a lens that we can use to analyze these issues. Now, of course, it is one example of medical tourism. I'll have to apologize in advance to my colleagues in Saskatoon. I tend to like to wander, so I'm going to try to stand behind the podium. But please feel free to use your microphone if I stray too far from your sphere of vision there. In any event, so stem cell tourism is one example of medical tourism, which of course is nothing new. When I did my master's studies in the UK, I spent some time touring Bath and the Roman spas there, where people would travel for weeks or even months to take the healing waters. So this has been around for millennia. And today people travel as part of medical tourism for an incredibly wide range of kinds of procedures and products, ranging from cosmetic to dentistry to orthopedic surgeries. We have organ trade, reproductive transplants, and then sort of engagement in this practice for experimental kinds of procedures like stem cells interventions that are not available in a jurisdiction. So there's a huge range of practices and an equally large range of motivations underlying someone's pursuit of medical tourism. The common focuses on things like wait times in a home jurisdiction, the availability of a treatment, the cost involved, perceptions regarding the quality of care, and others. So the motivations, I think, are as numerous as the people involved. Now here I adopt Crooks and Snyder's definition of medical tourism as the involving patients intentionally going abroad to pursue medical services outside of formal cross-border care arrangements and that are typically paid for out of pocket. So the key parts of this I want to highlight are the intentional aspect. So I'm not talking here about situations where someone is required to receive emergency medical care while they're overseas, so they break a leg while skiing or have a heart attack or have some other unforeseen medical situation arise. Also not talking about formal cross-border care, so where someone in a jurisdiction goes through their healthcare system to make arrangements for care to be provided elsewhere. This happens a lot between provinces, for example, or between Canada and the US, where patients are going back and forth, where expertise is available that is not available in a jurisdiction. But the procedure is still one that is covered by the domestic medical system and typically paid for out of pocket. So what we're talking about in this particular medical tourism market are services that individuals pay for directly. So it's not covered by their domestic medical system, usually also not covered by any kind of private insurance. So they do pay for it directly. Now, initial sort of research on medical tourism tended to focus primarily on patterns of sort of movement, I guess, where people would go from less developed countries to countries such as the United States, where the pursuit would be really focused on often expensive but really expert medical care, such as the Mayo Clinic as being kind of a standard example in that context. But over recent years, we've seen a growth and focus on medical tourism destinations emerging in lower to middle income countries, and often as part of a very deliberate economic development strategy. Now, in all of this, we cannot underestimate the role the internet has played in the growth of this market. Again, I think many of us have likely heard physicians and others complain about the phenomenon of Dr. Google, where patients will walk into an office with a stack of information printed off the internet where they have gathered data on their personal condition or have a long questions regarding potential interventions or treatments that they've come across. And that is sort of true, I think, to an exponential degree in the medical tourism industry, because individuals are empowered by the internet to not only become their own diagnosticians, but also referral specialists and even the travel agents that go along with it. In the majority of cases with these medical tourism clinics and operations around the world, individuals make connections directly. So they're not referred through a physician or any other kind of care provider. Arrangements are made to receive this treatment, again, usually online, directly with the clinics, and are paid for on that basis as well. So all of that also makes it a really complicated area to research. You may be wondering, how much of a problem is this? How many Canadians are engaged in medical tourism? Specifically, how many are coming back with problems that do actually require our system to intervene with follow-up care? Unfortunately, I don't have good answers to that. It is an incredibly complex field to research and difficult to get robust data on. Again, for a number of reasons, partly because of the online nature of the market, partly because we're not referring through individual physicians, so our family physicians and our medical system isn't tracking referrals on that basis. When you come back from being overseas, you're not asked by a Canadian border official whether you had medical treatment abroad. You may report on your purchase of alcohol or tobacco or whether you visited a farm, but no one asks whether you received medical treatment overseas or whether you have a new organ inside of you or a new cell. So it's a little facetious, but at the same time, it is a difficult phenomenon to get a good grasp on. And stem cell tourism, I think, is even more challenging than, or I would argue is potentially more challenging than many areas of medical tourism, particularly because it is such a fringe area and so experimental at the best of times. So what do I mean by stem cell tourism? I frame the definition in this way: the pursuit of allegedly stem cell-based interventions that fall outside the approved standard of care. Now, the allegedly is there in brackets because although the treatments that are being offered on clinic websites are framed as being stem cell-based interventions, in a number of cases there are some significant questions around whether the treatment provided actually contains stem cells, or in what concentration and in what combination with what other agents. So although stem cell is part of how it is framed, I think it's a very much an open question whether stem cells are part of the treatment in all instances. The key part is that it falls outside the approved standard of care. So we are not talking here about people traveling with leukemia, for example, to receive a bone marrow transplant. That is an approved standard of care for a condition here that does use stem cells. It's one of the limited examples where stem cell therapy is part of an approved standard of care. So I'm not addressing those kind of situations. We are looking at really the fringe area of the private market here, where stem cell treatments are being offered for conditions where there is not sufficient clinical evidence of safety or efficacy. Also to be distinguished, I guess, briefly from participation in clinical trials. So we're also not looking at individuals who are participating here in situations where there has been an approved clinical trial, subject to ethical oversight, peer review, where there is transparent data reporting, pre and post treatment follow-up, and all of that. So again, that's not looking at those kind of situations either. So where has this market come from? Stem cell research in general has generated a tremendous amount of excitement and enthusiasm among a diverse range of audiences over the last couple of decades, and particularly since, whether we pick the cloning of sheep in '97 or the derivation of the first human embryonic stem cell line in the late '90s, there's been a lot of attention given to this field, and I think the general consensus is that it does have tremendous potential in terms of improving our treatment protocols for a wide range of but it is also an incredibly challenging field of research, particularly when we're looking towards moving to routine clinical applications. And although there are clinical trials at various stages around the world, addressing various areas around the world, they are very much in early stages for the most part. So testing safety before we even get to efficacy, before even getting to whether these treatments work and how well do they work. But nonetheless, almost every sort of breakthrough on the clinical side, whether it be in small animal models or even in the petri dish, gets a lot of attention in the sphere, and often it's framed as being that breakthroughs are right around the corner. Some commentators who have studied this area have used the word hype to describe sort of the excitement and fervor that has surrounded this particular area of research. And indeed, I think it's fair to say that this hype, if we want to call it that, has been maximized by the emergence of a very robust and growing private market surrounding the offering of these kinds of therapies. So for example, all you have to do, if you're curious, is go to Google, type in stem cell therapy, stem cell treatment in combination with any number of conditions or diseases, and you will find clinics around the world offering treatments now, today, that are often framed as being promise to be effective, as even routine in some cases, for kind of a mind-bogglingly long list of conditions. So what does this market really look like? Again, it presents a significant research challenge for all the reasons I talked about already in relation to medical tourism more broadly. This particular market is even more challenging because in many cases these clinics are operating sort of in a very gray area, or even in purely not at all gray, because they are not legal in the jurisdictions they're operating in, or at best it's a gray area. So they're very fluid, and we see a lot of clinics that will emerge in a jurisdiction, but if they receive unfavorable press, for example, in relation to an adverse event that occurred, or if the regulators in the particular jurisdiction take a closer look at them, the clinic disappears or goes offline, emerges again in a new jurisdiction a number of months later, sometimes with the same name, sometimes slightly different, Inc. is added or LTD is added instead, but the same individuals are involved. So it's a fluid market that can make it difficult to track. Having said that, myself, members of my team, and other scholars working on this area have taken a variety of approaches to just really try to gather information on what this market looks like. And I hesitate to even call it data because there are so many limitations with all of this, but we have done blog studies, so studied the blogs of patients who have reported their own experiences. We've done analysis of clinic websites. We've done newspaper studies of media reports of individuals and individual experiences. So again, lots of limitations with all of this. I just want to give you a brief sample of what some of the things, what the market does sort of look like when we pull all of this information together. Clinic locations truly are around the world and are also moving into jurisdictions that traditionally are considered more tightly regulated for these kinds of practices, such as the United States and the United Kingdom. As I said, an incredibly wide range of diseases and conditions treated, ranging from multiple sclerosis to ALS to autism, traumatic brain injury, spinal cord injury, aging, other cosmetic issues, and others, right? So, I mean, really an incredibly broad range. Again, an incredibly broad range of cells used, so the kinds of stem cells used, ranging from human embryonic to fetal stem cells, umbilical cord blood. Adult autologous means from an individual's own blood cells, so your own blood is taken, sometimes manipulated in a certain extent, and then reintroduced. Others, and in combination, we see samples of animal stem cells being used, and even sometimes fruit stem cells. Lots of different methods of application: injection, intravenous, lumbar puncture, sometimes even oral or topical. And in many cases, the clinics are framed that they will use one method of application and one sort of cells that they report to treat an incredibly broad range of conditions, ranging from, for example, autism to ALS to spinal cord injury. So I think even those of us without a medical background, that would raise some red flags in terms of likely efficacy when we think about what we know of approved standard of care for these vastly different conditions. And cost is a really big question. It is not advertised on many websites, and when individuals report how much they've spent, it's often, of course, mixed in with travel expenses for themselves and often a supporter who goes. It's not clear what's all incorporated, so it's difficult to get a sense, but certainly the tens of thousands of dollars is where most of the studies come in at being kind of the average cost that is involved. Now, this is an issue that has attracted policy attention from a wide variety of levels, ranging from patient advocacy organizations putting forward advice to their members to be cautious around these particular therapies or regarding questions that they should at least ask before pursuing them. The same kind of educational-based approaches from scientific organizations, both in terms of advice to their scientific members or how they need to guard perhaps their own cell lines and ensure that if they are sharing their cell lines, they're doing so with good awareness of what they're being used for. And also advice, again, to patients. The International Society for Stem Cell Research has a patient handbook. So trying to arm individuals with information. So give people, members of the general public, better questions to ask, better sources of resources, sort of where they can go if they're interested in these kinds of things, and perhaps some, again, clues or cues to red flags that might caution them regarding clinics that may not be to their benefit to pursue. Various national governments, China, Japan, Germany, are tightening regulations, introducing new laws to address this area. The FBI and other regulators comparable in other countries are taking a firmer view regarding clinics that are operating in their own jurisdictions. So there is a lot of action going on in terms of addressing this particular phenomenon. But unfortunately, a recent update study suggests that it is not necessarily having a direct impact on the number of clinics that are out there, the kinds of treatments they're offering, or the jurisdictions in which they're operating. They are spreading. So this is, I think, very important, and we could spend a lot of time talking about these today, but that's not my focus. I highlight this because it's, again, these are big picture responses, and I think these will take time to show an overall impact in the growth of this market. But part of our focus in the current research is looking at more direct and efficient mechanisms to respond to an individual circumstance on a case-by-case basis as these kinds of situations arise and cause adverse events for individuals. This is just a quick sample of work we did also to highlight that the issue is becoming increasingly salient among the scientific community themselves. This was an anonymous email survey of active stem cell researchers, so scientists publishing in peer-reviewed, the top 20 peer-reviewed journals by impact factor, looking at how they perceive policy issues and their shifts in their jurisdictions over time. And I put it up here not to get into the details of policy issues more generally, but the circle that you can see around the column second from the right is in relation to unproven stem cell-based interventions. And the blue, which you can see is almost at 80%, 76% of participants rated unproven stem cell-based interventions as being the issue that they perceived as being the most contentious, or the greatest increase in degree to which it's a contentious or problematic issue in their jurisdiction over the last 10 years. So scientists who are working in the field see this as being an issue that is increasingly contentious, and they report it as being one that they are increasingly having to deal with, even if they are not sort of on a clinical position in terms of providing care to patients, but merely by virtue of their research in this field. Now, what is the cause for concern? Why is this a policy problem? There are a number of reasons for that. The biggest one, of course, is risk. We're concerned about risk to patients. Stem cell therapies, as I noted in the beginning of today's talk, are tremendously promising, but they're also challenging for a number of reasons, largely because of the rate at which stem cells differentiate. They can grow very quickly, and they can become, depending on what kind of stem cell we're talking about, any cell in the human body. Now, if we're thinking about what other kinds of cells grow quickly, So that is one of the big concerns around stem cell therapy, not only the growth of actual cancer tumors, but also tumors, lesions, and other formations that are difficult to control. So there are a number of published studies looking at case examples of individuals who have returned from having stem cell-based interventions abroad and have had a number of years later some quite serious reactions. Apart from that, there are also the risks associated with medical procedures generally. One of my colleagues in this area who does spinal cord research has sort of a phrase that I think is incredibly useful, and that is just that there is no medical condition known to humankind that cannot possibly be made worse by medical intervention. Right? There's always risks when it comes to medical intervention, and that is true in this case as well. Here you're dealing with cellular therapies, often in clinics where oversight may be lax. We're not sure, there's often insufficient evidence about that. So information regarding cell purification protocols and just the sterility of the environments are serious questions. So we're also having instances of people coming back with infections and meningitis and those kinds of risks that aren't specifically related to the stem cell aspect of this, but merely to medical treatment in situations where there may not be the kinds of stringency around safety that we would like to see. Apart from safety, there are also risks on the financial level to individuals. Again, when we're looking at the studies of blogs and newspaper reports, in many cases these are individuals who are remortgaging their houses, quitting their jobs to pursue this kind of treatment, and really putting all of their financial resources on the line. So the concern regarding financial risks people are incurring. Concerns regarding risks to the legitimacy and the reputation of stem cell science as a whole. So concerns that adverse events in this fringe market will impact on the overall support for the field of science and for this trajectory of research, which again people generally feel I think is quite promising. It needs time to grow and time to mature, and we're not there yet. But concerns again that this market and adverse events happening there may negatively impact support for that field. And also, as I said, concerns regarding impact on our domestic medical system. So where our providers are asked to provide care, whether on a pre-treatment basis in terms of testing protocols or on a post-treatment basis follow-up, that they may not feel equipped to provide, and the cost to our systems that are associated with that is another challenge. Also issues around queue jumping in our domestic systems, again, where someone perhaps may have expedited access to a specialist, for example, because of concerns they have upon return, whereas they would have had a longer wait to access that individual had they not gone abroad. So a lot of issues, that's just a quick summary, but those are some of the sources of concern here, so why people are devoting some attention to this particular field. Now we may come, sort of as a common, I guess, theme in responses that is this a situation of buyer beware, or it's up to individual persons. If we put aside the concerns regarding the impact to our domestic healthcare systems, put aside issues regarding risks to the legitimacy of the field of science overall, we focus specifically on the person. We can say, okay, maybe it's risky physically, perhaps it's financially risky, but really we all have the right to make whatever decisions we want about our own medical treatment, and we should be not trying to infringe on individuals' autonomy to do that. And indeed, here in Canada, we have a very stringent informed consent. Our law is very strong in that area. We respect individuals' right, assuming that they are adequately informed to make decisions about their own health care. The challenge is how informed are people in this particular context? What quality of information are they receiving from the providers of these treatments in order to be able to make a decision regarding assumption of those risks? And that remains very much an open question. Again, it's a serious area of research challenge to ascertain what kind of information is being provided. Varies very much. So this is just one particular approach we've taken to get a sense of the public face of this. So recognizing this does not refer to the information an individual patient receives from a prospective provider. So this is not kind of what I get from a clinic that I then decide, okay, I'm willing to assume those risks in your treatment. This is as a member of the general public who receives a lot of my access to information about health and science from the general media. What do I see as the face of this issue? And to get a sense of that, we did a content analysis of media newspaper articles published in Canada, the US, the UK, Australia, and New Zealand over a 3-year period. And our sample included 45 articles, which detailed the experience of 225 different patients. Now, as I noted earlier, we used this data to pull some information about the market generally, which I had put up before. We also coded the data for an overall impression of how is the media treating these kinds of stories? What is the nature of that representation? Are these stories being viewed positively, negatively, or is there a neutral kind of balanced tone? And part of that was what kind of quality of information is provided regarding, for example, the state of the science, regarding the states of evidence, regarding presence or absence of risk, those kinds of things. And you can see the blue here is the positive tone, and that increasingly from 2006 to the end of to the fall of 2009, overall the trend is that the newspaper articles were increasingly positive. There is a small dip there in 2008. You probably can't read the numbers, but where you see an increase of red on the fourth column from the right, that the stories that sort of reflected more of a negative or neutral tone there largely centered around the International Society for Stem Cell Research's publication of those patient guidelines that I flagged earlier. So again, for people working on a policy side of this, that's a little bit gratifying in terms of it does appear to have had some impact in terms of media reporting, but it was not a sustained impact. Positive tone went again. Again, there's lots of limitations around this, and it really does just give a sense that this is what the average member of the public is seeing in relation to this issue. Perhaps how they're first introduced to it is fairly positive, which is, again, only one small piece of the puzzle I think we need to think about as we talk about informed consent and whether individuals are actually making choices based on an adequate amount of information, but it is nonetheless a piece of the puzzle. So does this still leave us in a situation of buyer beware, where, having said all of that, we still get back to a place where individuals, again, particularly we recognize as dealing with difficult situations, perhaps a condition where there may not be an approved standard of care that is very promising or that is very effective for them, that we still get back to a position where they have, again, the right and the ability to make these choices and to do that. And I think that's a very fair position to have. I think there's a greater tension, however, when we consider the role of individuals who do not have decision-making capacity. So talking specifically here about minors who are not mature minors. So these are children who do not have the capacity from a legal perspective to make decisions about their own health care. And this is a real issue in this market. Again, data is fuzzy at best, difficult to have robust numbers, but when we look at the percentages of children involved in the blog studies, for example, in our media report, we're looking at the claims of clinics generally, it would appear that children do make up a very substantial portion of those involved in this particular market. And so that is a cause for concern. A colleague and I did a legal analysis here looking at physicians' responsibilities to minor patients in this particular context. And that analysis emerged out of a question, actually, we were asked at a conference by a physician who said, I'm a treating physician. He also was a stem cell researcher, so he was very sort of alive to this current state of the science. But in his role as a clinical provider, he sort of was consistently receiving questions and even at times going further than questions, but parents who wanted either advice about whether they should be taking their child overseas for this kind of treatment or simply informing them that they were going to be taking this child abroad. And he wanted to know what his obligations were. And his particular perspective was whether this could be considered a form of child abuse and might impose upon him a duty to report. And again, remember, this was an individual who was very alive to the scientific challenges, very cognizant of the lack of evidence supporting many of these treatments and of the risks involved. So it was a really interesting question and one that we didn't have a very good immediate answer to. So as I say, we did do a legal analysis of that, looking at case law, looking at precedent, looking at the various legislative obligations imposed in different jurisdictions, and also looking at the professional responsibilities in that context. I won't get into this in depth today because I think it's beyond the scope of the talk, but I'm happy to discuss it afterwards if anyone's interested. Where we were left with was a fairly unsatisfactory answer, I think, for many, in that it kind of came down to it depends. It's a very factually based decision that will determine on a number of factors. But it also got us rolling more generally on looking at the roles of physicians in this particular context. And again, these are relevant to stem cell tourism, but also to a lot of analogous areas. And that brought us to this particular research project, which is an examination of the role of professional regulation in addressing physician involvement in stem cell tourism. This is a public policy impact grant that is funded by the Stem Cell Network. And as I noted at the outset, it's a very brief project. These are intended to be very short-term grants. So initially, a year, we have 18 months sort of to wrap up all of the conclusions. So we are now just finishing gathering the data, a few little bits left out there, and starting on our analysis. So initially, I would have just been talking to you about what we were planning to do, and now I can report to you a bit on what we've done and the information we've gleaned thus far. And we did come at this from two different perspectives. One was sort of the plea from physicians, such as the one that approached us at the conference, in terms of feeling that they lack appropriate resources and support and guidance in how to act in these kinds of circumstances, what their legal and professional obligations are. And also from the direction of, again, hoping to look for and identify more direct and efficient mechanisms to deal with concerning situations when they arise. So recognizing the value of the bigger picture policy perspectives of legislative approaches in different jurisdictions, but also recognizing that we perhaps need a way to deal with concerning cases as they emerge now with frameworks that already exist, that do not require new legislation or a new policy approach on the part of government. So kind of frameworks that are here at present that might be applied to deal with situations that may be concerning. Now, just a bit of background, of course, in many jurisdictions around the world, medicine is a regulated profession. There are different kinds of regulatory approaches that govern the practice of medicine, ranging from self-regulation to purely state-focused and then hybrid approaches in between. Here in Canada, we operate under a self-regulatory approach to medicine, which means that every province in Canada and territory has a body that is statutorily empowered. So by provincial legislation, they are given the authority to regulate their members. And generally, across the board, where we have self-regulation for medical physicians or other disciplines as well, it is based on the underlying value of protection of the public, of serving the public interest. And that is sort of the basis upon which professions are granted the authority to self-regulate by the state. Now, again, there's a mix around the world at different levels, and even where there is that self-regulatory aspect, so where it's not the peer review that we see here in Canada, at the state level, still that protection of the public interest often plays a very fundamental role in terms of how the regulatory regime is structured. So again, as I said, in Canada, we have, each province has their own college that regulates the practice of physicians here. We have the College of Physicians and Surgeons of Saskatchewan, and they have a licensing role, they develop and regulate standards of practice, and they discipline members in relation to complaints from the public. They also have a policy arm, and this is true of many regulators around the world and certainly across Canada, where they produce advice and guidance to their members on a number of topics. This is just a screenshot of their website to give you a sense of the range. At the very top, we have assisted reproductive technology. There is guidance regarding patient-physician relationships, regarding renewal questions, sick slips, treating employees, unplanned pregnancy, and all the way down to unproven and unconventional treatment. So for this particular project, we were interested in both arms of regulators' roles here. So both the disciplinary aspect and the policy guidance aspect as being both important elements for this particular research. There were 4 phases to this project. The first was a series of case studies that we put together. Second, a field survey that had a couple of different components. Third, interviews. And fourth, a policy workshop. And I'll talk a little bit about each of these in detail. Again, we're getting into some really emerging research here. A lot of this is preliminary analysis, so you're getting it kind of hot off the press. I can't put up any publications yet as they are in progress. And so I'm also really looking forward to your feedback at the end of today's session on this research, on questions that emerge for you, because it is still, as I say, very fresh and ongoing. So this is part of why this is an excellent opportunity from my perspective as well to share these thoughts with you and get your perspectives and feedback. So as I noted, the case studies were the first kind of phase of this project. And here we wanted to gather information on existing examples of situations where professional discipline had been employed against a physician for his or her involvement in some form of stem cell treatment. We were interested in situations from around the world, gathering a range of examples, sort of reflect the different kinds of physician involvement that we see in this particular area. My research assistant Sonia is here today, and she was instrumental in a lot of this work, and it did involve a lot of investigation and pulling again together resources from a lot of different kinds of sources of publicly available information. Again, the limitations here were limited to English language resources and to information that was publicly available. A number of jurisdictions around the world, Canada being one of them, is fairly good at making their information publicly available regarding disciplinary matters where the disciplinary matter is concluded, but where complaints are received and the investigation does not proceed, for example, to a full hearing or a conclusion, that's not necessarily the case, and some jurisdictions simply don't make this conclusion at all. So this is by no means a comprehensive sample of all instances of professional discipline around the world in this area, but it does give us a sample of what's out there. And from our research and sort of survey of the initial scope of this, we really found, I guess, a spectrum, shall we say, of physician involvement, which is likely no great surprise. On one end, we can see situations of physicians who are being asked again to provide information or advice about the particular treatment, and I think this, it's fair to say, is the category where most Canadian physicians are facing at the moment. Now, that's not to say that there's a lot of complaints arising out of that, because that's not necessarily the case, of course, but that is sort of the perhaps lightest end of the spectrum. In the middle, we have a number of cases of physicians providing referrals to stem cell clinics overseas in other jurisdictions. In some cases, they are accompanying. In some cases, they are advertising services. In some cases, there appears to be a financial compensation aspect for the referral. In other cases, it is related to providing pre- and post-care, but not actually being involved in the actual provision of the stem cell-based treatment. And then finally, all the way, of course, to the far end, where physicians are providing the stem cell-based treatment themselves, again, without evidence of safety or efficacy. Now, naturally, each of these engage a number of different issues from a professional regulatory perspective, from a legal perspective, but there is this range involved. This is just one example, and it's one that you have chosen here because you may be familiar with it. It did receive some press here as well as over in the UK. It's a Dr. Robert Trossel who was struck off the medical register there for providing treatment to a number of different patients over a 2-year period between 2004 and 2006. The actual disciplinary hearing was in 2010, and he was treating patients with MS with a stem cell-based treatment along with another treatment that is also lacks evidence of safety or efficacy, not part of the standard of care. And there are a few particularly interesting parts of this case study. I used it to inform the interviews, which I'll talk about in a few minutes, because of the approach that was taken by the General Medical Council. Now, the first interesting part of this was that although Dr. Trossel made connections with some of these patients in the UK, much of the care was provided in the Netherlands at a clinic with which he was affiliated. And nonetheless, the Medical Council found that their jurisdiction extended to his conduct outside of the United Kingdom, which is interesting based on the patterns we see in this kind of market. And as I say, I'll come back to that, but I addressed this particular case with my interviews with Canadian regulators to see what their perspective on a similar approach would be. And it's also was interesting because of the key points that really hinged or sort of around which the General Medical Council framed their decision. And some of the things that they took into consideration were the fact that he failed to respect the rights of patients to be fully informed. He lacked the relevant expertise required for this particular research area. He did not provide adequate follow-up care or consultation. He abused his position as a doctor, and the overall treatment lacked rigor the rigor required for a medical practitioner to embark on pioneering treatment. So again, just to kind of keep these in mind as we look at some more of the cases that we go. These are, I think, themes that arguably are present in a lot of the other kinds of case studies that we pulled in other situations that arise. So it's a good example sort of the employment of an existing professional regulatory regime to address conduct in this area. Also interesting because a lot of this was not a situation where there were sort of really serious, egregious, or adverse reactions that occurred by the patient. But they nonetheless mobilized in relation to the care that was provided because it was such a far departure from the approved standard of care. Obviously, I don't have time, and I'm sure you're not interested in the details of all of our case studies. But this is just a sample, sort of an overview chart that gives you an example of the range that we saw. You can see there's the U.S. There's a few different situations here, or a few different states that are involved: California, Florida, Louisiana, which is relevant because, of course, different regulatory regimes are in place in different states across the U.S. They have different standards, different codes. Singapore, 2 different situations in Singapore, 2 different physicians, I should say, and a couple of them were involved in a number of different instances addressed in these complaints. Australia. And again, a wide range of charges, but with some consistent themes, centering on unprofessional conduct, negligence, professional misconduct, provision of unnecessary care, medical malpractice, fraudulent advertising. You can tell that the language changes in different jurisdictions. People have different codes, different standards of practice. They're framed differently, and yet the themes are often very consistent in terms of the overall approach. These were in relation to, again, a wide variety of kinds of treatment provided, which, as you think back to the overarching slide I showed at the beginning regarding the nature of the market and the wide range, I think that's exhibited here in the cases. We saw treatment for spinal cord injury, neck pain, for anti-aging, for ALS, cosmetic purposes, as well as chemotherapy-induced neuropathy, so nerve pain, various cardiovascular conditions. So again, a really wide range of kinds of things going on. And perhaps what I want to draw your attention to the most, though, are the range of results, because I think that is an important aspect of the use of professional regulation as a tool here. Because there is, again, a broad range of sanctions available to regulatory bodies, ranging from fines to continued education, to practice monitoring, all the way, of course, to suspensions or full restrictions of or revocation of licenses. But really, the results can be very specifically tailored to the particular facts at hand and to what the regulatory body views as being the most egregious parts of the conduct or the most concerning aspects, which I think is important and a very valuable tool in that respect. It does enable regulators to respond on a very case-by-case basis to the facts with which they are presented, which again, in an area that is an emerging area of science, such as stem cell research, I think that's valuable because the evidence does change very quickly. And it can be very difficult to assess on a global perspective and from a broad overarching policy level because the science moves quickly, standards change, and so one of the benefits of this kind of an approach is it views the case before it and responds on that basis. So I think that that's one of the benefits that's highlighted here. And we moved on to do a field survey, which had 2 branches, and these are all sort of linked at the end, so we'll come back to tying some of these different pieces together. The first branch of the field survey was to get a sense of what what is the medical face of stem cell tourism? To what degree are physicians engaged in this practice? Again, at sort of the face of the market level. And to do this, we use the data produced by two separate studies. These are colleagues of mine, two of which are co-investigators on this particular project in Caulfield and Ibaka-Obugu at the University of Alberta. The first study there, the Lau et al. Piece from 2008, was really the first kind of research in this particular field that did a very close and comprehensive look at what these websites are offering. So it was a content analysis of all the websites they could gather using Google search engines addressing stem cell therapy over a period. So they gathered all the websites. They did a content analysis of those websites to look at what treatments were being offered, how were the claims made, what nature of treatment protocols were being used, referred to, what patients were they targeting, conditions. So very comprehensive in that respect. And then they matched the claims made on those websites to evidence published in peer-reviewed literature. So matching the conditions treated for the actual PubMed data in relation to standard of care of those treatments. And that was sort of the first bit of research that supported the conclusion that these treatments are not supported by published peer-reviewed evidence of clinical safety or efficacy. So we could have used that data. We updated that data, members of our team, in 2013. So looking at those same websites and comparing them, doing the search again in 2012, published in 2013, but to look at what has changed. So what have the numbers of clinics changed? Where are they operating now? Have their claims changed in terms of what treatments they're providing, how they frame those as, whether it's routine, experimental, those kinds of things. So that's what these two pieces address. We pulled the data from that and went through the websites to look at the degree to which they named particular physicians or made reference to physicians generally as being involved in their practice. And this is just a very broad summary. In 2007, you can see, overall, so the clinics that were gathered in the 2008 published piece, the data was actually gathered in 2007. There were 19 clinics that made reference to a doctor or doctors, and 19 clinics again in the 2013 paper, which is just coincidence that it was 19 in both, also made reference to a doctor or physician. There was a broad category of physicians involved, ranging from just a basic MD to various specialties, neurosurgeons, also OBGYNs, anesthesiologists, and others. Some reference merely to individuals who hold a PhD or other credentials, but not a medical doctor. Also, holistic, naturopathic, or traditional Chinese medicine doctors were there to a much more minor extent, and some reference to just unspecified doctors, so with no comment on specialty. Now, from here, we went a step further to try to ascertain the degree to which the individuals mentioned on these websites actually held active licenses in the jurisdictions which they were associated. Again, Sonia was instrumental here. A lot of investigatory work, rolling up sleeves and doing some digging. Lots of limitations here. So again, we can't claim that this is necessarily robust because we do not have enough information about the registration procedures in all of the jurisdictions affected and the degree to which their records are up to date or complete, those kinds of things. So all we can do is kind of have a sense. But it does give us a picture that certainly in some instances these individuals do appear to hold active licenses. Come back to that. As part of that, we are doing, as the next step, a jurisdictional overview where we're looking at the actual regulatory environment in the jurisdictions impacted by that. So looking at what regulatory structure is in place for physicians there, what are the relevant codes or practices, codes of ethics, regulations, standard of practice. Depending on the jurisdiction, there's a large variety of how it's framed. Looking at the disciplinary procedures in place in those particular areas, with a view to ultimately informing a comparative overview of how the different kinds of conduct that we've found through the case studies and through other reports would be viewed or how they fall underneath the existing regulatory regimes in these particular countries. And India is a really good example because when we looked at the websites of the clinics from the analysis previous slide, 3 of the clinics reviewed had approximately 50% of their physicians named that appear to hold active licenses. Now again, there are limitations around all of this, but if we sort of take that at face value, that's interesting on 2 levels. First, that perhaps, whether it's exactly 50% or if some of them, the records aren't licensed, but certainly a proportion, it would appear, of the physicians noted do not hold active licenses, which that's important, I think, on one level. For this particular project, though, equally relevant is the fact that approximately half the physicians do hold active licenses, which means that they are subject to professional regulation. And India is a jurisdiction that has a medical council at the federal level as well as state-level councils, and each has sort of different levels of responsibility in terms of regulation of their members, codes of ethics in place, standards. Now there appears to be some some challenges in terms of the degree to which there is active enforcement, some challenges regarding the proliferation of individuals who perhaps are not adequately qualified or licensed and yet without sufficient enforcement. But nonetheless, the general framework is in place, it would appear. So it's an interesting case study in that regard, as an area that does have the framework in place to address situations that may be concerning, that may violate the codes of ethics and the standards that are in place there. So this is just kind of one example. Now we went on to do some interviews here in Canada with two different groups. The first being representatives of provincial colleges of physicians and surgeons, and the second being practicing physicians and medical students and residents. Now, these are still ongoing. To date, I've interviewed 6 representatives, or representatives from 6 of our provincial colleges, which I'm happy about their willingness to engage on this particular issue, as well as a number of physicians. And these were semi-structured interviews focused on kind of 2 broad issues, or sort of 2 themes we wanted to probe with each of these groups. The first was the representatives of provincial colleges and surgeons, looking to inform us as to how they would view this particular area. To date, I'm only aware of one college that has dealt with a particular complaint in regards to stem cell tourism specifically. But they have dealt with any number of complaints in terms of analogous areas. And so wanting to know how they would view this particular area, how they would see it falling underneath their regulatory structure in place in regards to their codes of conduct in their province, and whether they see it as an area that perhaps needs some further policy development, where they would look to providing some guidance to their members, and if so, what that might look like, what their obligations of their members would be in these different contexts. And secondly, in relation to the physicians and the med students, what their perspectives are, how they view their own professional and legal obligations in these contexts, where they see the role of professional regulators in responding to these kinds of situations, and where, again, they see potential gaps that exist or uncertainties. And for these interviews, we used case studies to sort of really boil them down to some very concrete examples that we could use as a basis for discussion. Again, it was semi-structured, so probing some of these key points, but also giving our interviewees a lot of room to share their perspectives and their thoughts, and to give us kind of their view on how they see this particular topic. They were recorded and transcribed and put through a sort of a coding frame with a couple of different coders. This analysis is very preliminary, so this may change, but at present, there are a number of key themes that are emerging from these interviews. And really central to all of the interviews was a focus on standard of care. So as kind of being a key part of the analysis, if we are presenting a factual scenario where an individual is either providing a stem cell treatment, for example, or referring to a stem cell treatment elsewhere, asking whether that is the standard of care. And if not, then asking some really hard questions about whether it is at all appropriate for that physician to be either providing the treatment or to be referring an individual to it. And even in terms of counseling and providing advice, again, if it's not standard of care, that really does raise a number of obligations in terms of what the physician is required to discuss and to raise with that patient. Again, there's a lot of overlap between these various pieces. Informed consent came up quite frequently, the value that we place on informed consent in our systems, we've already discussed today, but also recognizing the challenges that go along with that in this particular context regarding not knowing the degree to which individuals are receiving adequate information to make an informed decision. Evidence, so the challenge again of looking to whether there is sufficient evidence to support this particular treatment. So if we're looking at individuals providing the treatment here, then the colleges particularly were very firm that there better be evidence of safety and efficacy before it's provided. If we're referring out, still recognizing that there needs to be some evidence that it may provide a benefit to this patient and certainly not provide harm, something a number of the respondents focused on. A lot of concern around financial benefits and conflict of interest. So when we are looking at situations where physicians appear to have a financial relationship with a referral clinic, and perhaps getting a kickback, for example, that was a source of significant concern for the regulators. And they made a lot of analogies here to other situations where they've had, for example, members who have been affiliated with a vitamin company in the States, so they're recommending that patients purchase these vitamins online and they get a financial kickback as being a source of conflict of interest that would be viewed dimly by the regulators. And more broadly, sort of recognizing that if a physician does have a financial interest in a particular treatment approach, that needs to be disclosed to the patient, and that needs to be something that's part of the individual's decision-making kind of package, as it were. A lot of recognition of the knowledge limitations and challenges regarding what is fair to expect, fair and reasonable to expect of our physicians. particularly if we're looking at family physicians, they are exposed to an incredibly wide range of issues on a daily basis and have a lot of limitations regarding the degree to which they can stay up on really cutting areas of science, biomedical research. So, having that patient come before them and asking for information about something that they know nothing about, but also the challenge that they're in a very busy practice. And although in a perfect world, you may want them to go out and do research and come back and present that to a patient, the reality is a lot of physicians don't feel that they have the time or the capacity to do that. So kind of a real tension there, and that was a source of some tension and perhaps a difference of opinion in some cases between the colleges and our physician respondents. A lot of focus on the duty to treat. So although, again, I'll talk about this more in a minute, but in the context of the MS liberation issue, this was something that a lot of the colleges dealt with from their members. So some challenges and reluctance in some cases to provide follow-up care, partly because they said, the suggestion that they don't have the expertise required, but also the colleges recognizing and hoping that their members recognize that duty to treat a patient who is employed, particularly if there is an emergent situation. And the overall concern with taking a physician more broadly, that because a patient goes and does something with which the physician does not agree, that enables a physician to withhold care. And that's sort of a serious issue from a health policy perspective more broadly, and certainly a tension that arose in our interviews. And finally, a respect for patient autonomy, tied again to informed consent, but recognizing that individuals do, of course, have the right to make their own decisions with regard to their health. But again, the tension here for looking at minor patients and others who do not perhaps have that decision-making capacity. Now, all of our respondents, and particularly the colleges, drew on other areas with which they have more experience in order to form their perspectives on this particular topic. So they drew on the left here, sort of two areas with which a lot of the colleges in Canada have produced policy guidance to their members. So the first is complementary alternative medicine, CAM, and secondly, medical tourism more generally. So they look to these areas and the policy guidance they've already developed as providing a framework for how they would give advice to their members on this area and how they would view this. So where colleges fell in terms of whether they would view stem cell tourism as an example of complementary alternative medicine or as an example of medical tourism differed to some extent, I think, based on the degree to which they have well-developed guidance on one or the other, or both. But they certainly drew from those areas. And again, that links into all of the themes I've already discussed in terms of whether there is evidence of safety or efficacy, lack of risk, and to inform consent, and that overall sort of standard of care as being central to that. The medical tourism piece really did keep coming back to the issue of MS liberation, and for me sort of highlighted the overlap between many of these areas, because that was something that is so current. It's a challenge that was dealt with here across Canada over the last few years, and colleges did provide direct guidance to their members in terms of the duty to treat, how to provide follow-up care in that particular context. So it was sort of a very fresh source for them in terms of drawing analogies for how they would bring guidance here. And then last on the far right, in terms of research and innovation capacity here. So asking that question, that if this is not the approved standard of care, then is it research a physician is engaging in, for example, if they are directly providing the treatment? And an example here that was used was the autologous administration of cells that we're seeing in the United States. So people who are baseball fans may have followed stories of certain elite athletes who had shoulder injuries and received stem cell treatment to treat those orthopedic. I'm not a baseball fan now, and I can't even remember the athletes' names, but those of you who are would probably know him. But it got a lot of press, along with some fairly high-profile people in the football world. There have been getting press around this as well. So physicians taking these athletes' own cells, manipulating them, and reinserting them to a sort of as the site of orthopedic injury, with apparently positive results. So asking here, if that happened here, viewing, is that research that the physician is engaging in? And if so, has it been approved by a research ethics board? Has it been subject to the appropriate levels of peer review and ethical oversight? If it is not research, are we looking at a situation of innovation or compassionate care? Because, of course, not all kinds of medical practice come through the clinical trial route. Not everything can go through a double-blind, placebo-controlled clinical trial. There are lots of examples of medical innovation, particularly in surgical paradigms and others. So is this one of those? But if not, if it is, then there still needs to be some kind of preclinical evidence of safety, of efficacy. There needs to be that peer oversight. There needs to be transparency in the results so that they can be ultimately reproduced. So there are some key elements that need to be present in order for it to be an appropriate situation for medically responsible innovation or compassionate care. So this is kind of the framework as viewed from our Canadian regulators in terms of how they view this perspective. And we took all of these pieces, almost finished, this is the last piece, brought all of these different pieces together at a policy workshop that we held on March 7th in Edmonton with our team, as well as some other experts in medical tourism, practicing physician. And the point of this was to bring all of the pieces of this research together and to produce some ultimate conclusions in terms of what do we think about the role of professional regulation in responding to physician involvement in stem cell tourism. And as I hope has come through today's talk, I think there are a lot of strengths in the application of that particular framework, in that it is direct, it is relatively efficient, it can respond on a very factual basis to the particular situation in front of it. There is a wide range of options available to regulators, and it sort of draws upon a framework that is already in place. So as I said earlier, it does not require the mobilization of new policy efforts or new policy schemes, but uses something that's already there. It has a number of challenges. Many of these systems operate on a complaint basis, so it requires people to know that they have the ability to make a complaint. It also requires people to be motivated to go through that process. This is not like the civil tort situation where someone will be pursuing a significant financial reward potentially, or to have to seek compensation for injury or harm, because that's not usually that's not usually an option available to regulators here. So it requires people to sort of be willing to commit to this process and to go forward with this without necessarily having that particular outcome in mind. So there are a number of challenges, but I think it is a very valuable tool. It is one that certainly bears further examination. And at present, we are sort of writing up all of this data to provide ultimate sort of best practices and policy guidance to our Canadian regulators, and ultimately, hopefully, a bit of a roadmap as well for international and disciplinary bodies. And our Canadian regulators are receptors of this work, so they participated in our interviews, and we will be running all of our sort of drafts by them in terms of the policy guidance and getting their feedback on that level. So hopefully, it will have some direct uptake and really be a tool or a resource. So we're not sort of saying that we know best and that this is what you should do, but more sort of here are some resources to draw upon should you decide to produce guidance to your members in this area, or to perhaps work from in fine-tuning your own regulatory responses. So with that, I have to thank my wonderful colleagues on this project, my co-investigators, Tim Caulfield and Ibako Fuku, as well as Sonia, some other members of our team, Kristen Rachel is a good master, and this research, as I noted, was funded by the Stem Cell Network, so thank you as well to them. And with that, I thank all of you for your attention today, and would like to open the floor for questions and discussion.
Does anyone here at the University of Regina want to start? Does anyone have a question?
Thanks, Amy. That was a really great talk. My question, I guess, sort of focuses around the duty to treat, but I'm just wondering in your interviews with physicians and providers whether or not there was any discussion as to the fact that a lot of these times these patients are seeking these treatments against the advice of their practitioner, and what that does to the physician-patient relationship, and does it ever get to a point where you can't go back, and so that duty to treat may actually be have a negative impact on care going forward?
That is an excellent question, and there are so many parts of that I want to respond to. There's a lot of, I think, as I say, really important pieces to that, and you've absolutely hit on a really, I think, significant area of concern, both for physicians and for the colleges. So a theme in the interviews certainly was kind of protection of that physician-patient relationship and the trust that's involved there, and concerns around potentially violating that trust if a physician takes an overly firm position against a patient going. So if they are being approached, for example, by someone preemptively, so before a person is gone or before they've necessarily made that decision to go, there is certainly with a certain theme around reluctance to take a really firm position, trying to dissuade them, recognizing, or the sort of concern being that the patient is going to go anyway, and that exactly to say that position of trust, that relationship may be fractured, and that may mean that individual is not able to get the follow-up care that they might need to have on a return basis. Now, in terms of, again, not a lot of the colleges that we've dealt with in Canada have dealt with stem cell tourism in particular, but that was something that was sort of a broader theme in medical tourism more generally, and in relation to the MSc-CSVI. It's also, though, in relation to medical tourism, an area that people have researched with in terms of interviews with patients, and I think this is one where stem cell tourism is only one example of this broader. So if I can speak to the broader level, that is absolutely a theme that has been recognized, and it would appear from the research gathered to date, again, just from interviews with patients and with providers in the medical tourism context, the majority of patients are not necessarily seeking out advice from their physicians in advance. They are more commonly coming after they've made the decision to go and often it is in the context of seeking certain tests or procedures that need to be done in advance. So they're seeing it more at that level and or sort of upon return where they're wanting follow-up care. So they're not necessarily getting to wade in at the initial level. So it's that decision of if someone's already made the decision, to what extent does a physician comply with requests for tests that they might not otherwise offer? To what extent do they, even though it appears a decision has been made, actually still try to perhaps change that person's mind? And then on the follow-up basis, how do they deal with that and kind of maintain that relationship, recognizing that they have concerns regarding safety and this person is going to need follow-up care. And so how do they protect a relationship that will still have that person getting the care that they need upon return? So those are, I think, sources of real concern for both physicians and the regulators, and ones for which there isn't not a lot of really solid answers at the moment. It's an area very much of tension, and where people, especially at the physician level, are feeling a lot of difficulty, and they're feeling that obligation with the system in terms of not wanting to, for example, in the pre and post testing world, provide resources they would not otherwise provide that patient by virtue of this, but at the same time recognizing they have that duty to treat, they have that patient-physician relationship, and if they have a long-term relationship with that patient, they're also a fiduciary of that patient. They have to act in their best interests, right? So a lot of significant tension there. So thank you. I don't know if that was a very strong, it's a really complicated area, and I think that trust piece that you flagged is one that is a big concern for a lot of people, both on the regulator side, but also of the practicing physicians.
Anyone at the U of S?
No question here.
Anyone here?
Hi, good to see you.
You too.
I'm Larry Weiser. I'm a physician in active practice, and my interest was in liberation therapy, which has kind of died a natural death right now. But in my research with people going for liberation therapy, it was money, all the way. And somehow these physicians that were doing this had kind of divorced their ideal of you look after the patient because there is a medical innocence in all patients. And in that sense, I think Google is one of the worst things. And I predicted this 3 years ago in a publication. That Google is going to be almost a nemesis of medicine because people think that they know and they don't know. About the human body is very complex, and just adding all these new things that are unproven therapies is a recipe for disaster. So I was just wondering, I guess, you dealt very well with the media, which I thought was probably one of they fan the flames. But I just was wondering if you had a statement or did you find in these money all the time, the chasing of money unethically, I might add, by physicians?
I think that's an important point. The financial aspect of this market, I think, is quite significant. Again, as I said, the data is really hard to get in terms of how much are people spending or what. But these are not non-for-profit clinics that are operating. These are not part of statewide medical systems. These treatments often seem to cost in the tens of thousands of dollars, as I indicated, for one time, and that does not include the other costs involved with that sort of. So the travel and the accommodation and all of that. Never mind that when people return to medical systems, not every system is like our own, where you can show up at an emergency room and get care that you require, right? So in some cases, they return home and need care that is not necessarily covered as well. So the financial aspect is absolutely enormous, I think. And certainly there are commentators and scholars working on this field who go a lot further than I do in terms of their language around this particular market. Some have used the F word in legal circles, the fraud, to describe it as basically fraudulent. Certainly the profit motive appears to be very significant in terms of many of the clinics. And again, I don't want to paint everything with the same brush, but I think you're right that it does play a significant role.
Anyone else?
This might be outside the scope. I'm not into the medical field myself, but it seems to me, and as a librarian, this is an issue that's important to me, that there seems to be an asymmetry of access to information regarding the Google piece. On one side we can say Google's the enemy, but on the other side, maybe PubMed needs to learn how to use Google a little bit better as well, and make sure that the good information resources about health information, the useful ones, are the ones that are showing at the top as opposed to the commercial ones. So in some ways, I think part of the issue here is or one response that we could look at this is just simply an access to health information response. How can we better ensure that people have access to the right information? Because in reality, PubMed, is not that friendly. You only get the abstracts, and if you want to see the actual details, you got to pay big bucks. So in other words, in some ways too, it's money, 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 but on the other side. So I wonder maybe if you could just comment a little bit on that as well.
No, that's an excellent point, and I couldn't agree more. And I think, and you're right, even if you have access to the full article, it's not necessarily one that you can digest if you don't have a medical background in terms of the actual published evidence on the scientific perspective. And I think that's where, the sort of one quick slide I put up in terms of the efforts that are ongoing, there is sort of a focus on that, and in terms of improving the information and resources available to people overall. And I think a key part of that needs to be also looking at, which maybe we'll get to do in our next one if we get successful, but we'll be looking at improving the way in which we disseminate that information. So I think it's not sufficient to create a patient handbook, for example, that puts some key questions to ask, raises some red flags around claims that you might want to be concerned about, that kind of gives the layperson summary about the state of stem cell science. But where do we put that information that people actually find it? It's not enough to sort of put it on a scientifically based website, perhaps, or the website of our health law institute or our group. That's one place, but we need to think about, I think you're right, more proactively, how does that information get out there in a way that's actually going to get to people who are looking for information on this particular topic or other areas. That's a science communication piece or science literacy piece more broadly. But I think it's a fair comment, not only in relation to this, but science communication more generally. That is perhaps part of the responsibility of those working within the field in terms of how do we more effectively communicate our work to the general public. That's an excellent point. Thank you.
Anyone else? U of S, I'll give it to you, just in case.
No questions here.
Thanks.
Or have either been tremendously clear or very confusing? I'm happy to hover after if anyone has anything they'd like to discuss, not in the group setting, but yes, then thank you all very much for being here today and for your attention. Hi, it's so nice to see you.
It's nice to see you too. How's your daughter doing?
Well, thank you. As you can imagine, you would know better than anyone.
How long was she in neonatal ICU?
3 months. But she was 13 weeks early, so she was born at 27
oh,
weeks. So that was kind of what you were told to expect. We aimed to get out around her due date, and we got out 8 days before her due date. So.
Yeah, she was born like about a week after we had our meeting.
She was, I know, yeah.
Anyway, excellent presentation. I'm glad to hear it. So, yeah, it was funny because the liberation therapy kind of died a natural death. They did exactly the right thing. They just you go down, moved it down to the States for volume. Nobody showed up. Kind of made the decision. Anyway, well, it's good to see you again. I'm glad. I hope so. Yeah. And what was your daughter's name? Kinsley. Okay. Good. Okay.
Thank you for coming.
Oh, thank you.
Maybe it's not a quick question. It's probably a loaded question.
We have 20 minutes.
So where do you think the next major policy move is with regards to not just stem cell tourism, but medical tourism in general?
I think it's going to be in relation to the pre and post care issue, to be honest.
So, in saying that, I kept thinking when you brought up fraud too, it made me kind of think about it. It's the idea that would a physician if it's not in the standard of care, if it's not in a practice guideline, would they not have the right to refuse?
Oh, absolutely.
So that at that point there really isn't a duty to treat because it's not a recognized, like I just think we have CADIS that technologies go through for approving. If it hasn't been Health Canada approved or that sort of thing, there really is no duty to treat.
Certainly not on the pre,
right?
not before they go,
Right.
before sort of taking out the issue upon return. But if we're looking at pre, no, certainly not. I mean, it's in their decision-making power to decide what is the treatment that is medically indicated for that particular patient. But I think that this is where, I mean, it's easy to say that, but this is where the physician-patient relationship and the trust aspect you flagged is huge for people, because they don't want to fracture that trust, and they're concerned.
Although I kind of see it from the other way. In some ways, I think they almost want to, because from like the physicians that I work with, it's the idea that when there is absolutely no evidence to support it, they feel that they're not in a position then to be able to treat that patient.
No, absolutely.
Because they feel that they're constantly being undermined, right? And it's like, well, if you know better, then go see somebody that, will jump at, you say, I want this. It's the same thing with people coming in going, I want this drug. Or something saying, well.
It's kind of like the doctor just wants to say, I believe in monogamy. Either you're with me or you're with him.
Yeah, and it's sort of like this goes, and if there is a fundamental, you talk about the liberation. There were a lot of neurologists that were like, I'm not treating.
Oh, absolutely.
I do not believe in this. And so then I feel like, well, why should you then have to treat someone that has clearly gone against your medical advice, and in which you now no longer feel you have that ability to provide a level of care to?
No, I completely. I mean, there's so many pieces. Well, and it's that's the piece of it too, because especially if we look in the return context and take it out of a situation where this isn't someone who's requiring emergent medical in terms of general follow-up. But if we are saying it is okay as a policy position for physicians to not provide treatment because a patient does not follow their advice, for example, have gone elsewhere, so what about patients who have smoked and who are not following healthy lifestyles, who skied out of bounds? Are we really going to empower physicians to determine who cannot have medical? I mean, that's a tricky position,
that's where
right?
That's where
it's difficult.
Because you said a question.
Generally, when we talk about physicians not treating somebody, we talk about there's treatment that they don't want to do, not something based on your past action or something like that, but like if your follow-up care is that they had to give you injections or whatever this other doctor said, then the doctor can say, no, I don't want to do that. But if it's like you came back with a kidney and
I don't feel well,
I don't feel well, then they have to intervene and try to figure out what action.
Yeah, or I used to even think K-Mate, right? Like when everybody went to Poland for the liberation treatment, the stents. Well, the stents that they use there they're subpar. People were stroking because they migrated, right?
And the concern there was some physicians were refusing care,
right?
And so some people had and so that's what prompted some of the colleges to provide advice to their members saying, we know this is a problem, but you still need to treat it. And here's maybe some things to look for. Like it's was where the colleges did step in some cases to say, you still have an obligation here, and we'll give you some tools to help arm you, because we recognize this is not our standard practice. You don't necessarily know what you're looking for, but at the same time, we can't have people who are having adverse consequences that aren't being investigated, right? So
I kind of just so fast.
It's so
it's frustrating at the same time, because you don't have. I mean, you're right. You don't have somebody coming. Although it would be interesting if you were to ask, have you gone? Have you sought medical care?
On our customs forms, I know, I loved it.
Because I'm thinking, like, how is
I have to run, but I'll let you guys talk. But I just wanted to say that was really good. I'm glad I got a chance to.
Thank you. Well, thank you for coming.
Yeah, it was really nice getting a chance to meet you.
Likewise. Take care. Have a safe trip back.
So, would you see that as a policy?
I don't see that ever happen. I mean, the privacy concerns alone associated with that, because there's nothing illegal about going, and they don't have any. It would be wonderful from a research perspective, but. And there's such a range,
I feel like, well, yours is far worse than what my challenge was. I mean, the data's out there, it's just not collected, right? Like, it's big, it's very easy to do, but I just feel like I kept thinking about, what are the solutions to the data? Really, what are the, how can you work with it? Because I know that they, Kai tried to do it for liberation treatment, right? Yeah. They wanted to have the MS registry part of the MS, but then it was the idea that
you're still depending on people reporting,
right? Because
knowing about it, reporting.
People were afraid of disclosing it, because if their doctor found out that they did go and do it, then they were worried, again, like you're saying, they were worried. So I keep thinking, do you have an idea of how that can be improved?
I honestly have no idea, and I have spent some considerable time.
Well, I imagine that's why I'm curious to know.
I don't know. I mean, because it's just so anecdotal, right? It is so anecdotal, and even when you're talking to physicians, or you're talking to you're missing so many.
Right.